any organ, it's always better to have a basic knowledge about its anatomy and the cells which constitute the organ, so that we can easily understand the classification of a tumors of that organ and then understand it. So I've maximum try to put myself in a very simple way so that I make myself clear. Okay, today, I'll start my topic as a testicular tumor, first topic. And this is a anatomy cross section of a testis with a spermatic cord. Okay, the testis, it is covered by the tunica albuginea and vaginalis. The cross sections reveals many coil structures which are separated by septa. They are called the seminiferous tubules. This is the place where the sperms are produced. Now, these coil structures together unite to form the retitestis, and from there they start as the epididymis, and this is the place where the sperms which are produced in the seminiferous tubules gain its motility. Basic knowledge about this is needed to understand the further classification. Okay, so now this is the light microscopic feature of the seminiferous tubules. These round structures, in H&E stains, they are all the seminiferous tubules, and in the lumen you can find the spermatids. These seminiferous tubules, the tubular structures, they are separated by the fibrous septa. Okay. Now, this is a schematic diagram showing the single seminiferous tubule. You can find the basal lamina, and within the seminiferous tubule, you find the spermatogonia, and between them, you can find the Sertoli cells, which are supporting cells and nursing cells for the spermatogonia. The sperms which are produced are, they go into the lumen. And outside the seminiferous tubules, you can find the Leydig cells. So this is a H&E stain showing further magnified image. From this only, you are going to understand the classification. So these are two, on either side, above and below, you find the seminiferous tubules. And in between them, you have the fibrous septa. Okay, so the seminiferous tubule, if we observe the lowermost layer of cells, they are called as the germ cells. And above and between the germ cells, you can note the Sertoli cells. And between the two seminiferous tubule, I told you the cells fibrous septa. In that area, you find nice eosinophilic big cells with abundant cytoplasm. They are called as the Leydig cells. So from this only, I'm going to go to the classification of the testis, okay, testicular tumors. Now, this is the classification of the testicular tumor. I've maximally tried to put like a jumbles. I have separated this into pieces and then assembled it into this full classification schedule. Okay, first we'll see what is this. The testicular tumors are classified under three headings. One is a primary tumor, the other is a secondary tumor, next is a paratesticular neoplasms. Okay, the primary tumor, again you classify them into germ cell tumor and non-germ cell tumor. Now going back to the previous slide, I put the seminiferous tubules, the basal most layer is the germ cell I told you. So those tumors which arise from these germ cells are called as a germ cell tumors. And the tumors which arise from the other cells, apart from these germ cells, they are called as a non-germ cell tumor. Now, going back to the classification again. Sorry. See, now the primary tumor classified into germ cell tumor and non-germ cell tumor. Now going back to germ cell tumor, which is further subdivided, subclassified into seminomatous germ cell tumors and non-seminomatous germ cell tumors. This classification, I have put this sub-classification, I have put it in a simplified form in the next slide. So the main one, primary tumor, go on to the germ cell tumor, then that is further classified into seminomatous and non-seminomatous. Follow this in the next slide. Okay, now the primary germ cell I've already told you, no? So this primary germ cell, if it does not undergo any tissue differentiation, it can either become a seminoma or spermatocytic seminoma. So this is the, if the tissue does not undergo any differentiation. Whereas if the tissue undergoes embryonal differentiation, it becomes an embryonal carcinoma or teratoma. If the germ cell undergoes extra-embryonic differentiation, like the yolk sac, placenta and all, they become a yolk sac tumor and choriocarcinoma. And composite ones are the mixture of all these things. So this is what I have told in the previous slide. Now coming back to the claim classification, follow me through this: primary tumor, germ cell tumor, then the seminomatous and non-seminomatous. And the non-seminomatous, I have taken you to the next slide with, okay, non-seminomatous, the next slide, which is which undergoes embryonal differentiation as embryonal carcinoma or teratoma. Extraembryonal is yolk sac tumor or choriocarcinoma, and the mixed tumors. Now, first we will deal individually all these things as small subheadings, and then we'll come together and come back to the main classification. Now, to start with it, I will start with the primary germ cell tumor without tissue differentiation. First is a seminoma. Okay. See, the seminoma. It's actually very difficult to put this classification within the small screen without interaction. So I have tried to simplify myself and present you as much simple as possible. Okay, today, the first tumor I'm going to discuss was a seminoma. It's more common in the third decade. And usually the undescended testes are the predisposing factors. The molecular genetics, if we take, the reduplication of the short arm of chromosome 12, that is found in the cases of seminoma, thought to be responsible. And you can find mutations such as OCT3x4 and NANOG and KIT mutations. These seminomas spread by lymphatics and the hematogenous blood pathway, okay. When we what we see in the gross is something when we receive the resected specimen from the surgeon, which is fixed in 10% buffered formalin, you will find the that tissues in the same original condition without getting distorted, all the structures. So how will it appear, the seminoma? It will appear, this is the testis, and the mass is well circumscribed mass, and it will be bulky, and almost the entire testis will be replaced by the mass. And as far as the weight, it will be 10 times the normal weight of the testis. When you cut, it will be gray, white, and homogeneous. Microscopy, you will see large polyhedral cells with clear cytoplasm and the central nucleus. And of note is that these sheets of the cells will be divided into lobules separated by septa containing lymphocytic infiltration. I will show you in the slide clearly. This is a typical seminoma. It's a light microscopic picture. See the large cells, sheets of cells which are large and polygonal. You can see the centrally placed nucleus and clear abundant cytoplasm. These two, they are separated by a fibrous septa. And you can see the lymphocytic infiltration in between. This is how the seminoma will appear in a light microscope. Okay, and IHC immunohistochemistry, they'll be positive for placental alkaline phosphatase, CD117, OCT3x4, SAL4, and cytokeratin. These tumors are highly radiosensitive and it is often curable. Okay, we have finished one germ cell tumor without differentiation. This is seminoma, and the other heading is spermatocytic seminoma. This is a rare tumor, but it's a slow growing and usually found in people who are aged over 45 years. And this tumors usually they are bilateral. They do not metastasize, and hence the prognosis will be very good. Okay, grossly how it will be. See, in the seminoma, how it was, it almost occupied the entire testis, whereas here it will be only 3 to 25 centimeters. It will bulge. You can see the tumor which is bulging out from the surface, the normal testicular parenchyma, and it appears itself to be gelatinous, mucinous, and edematous, very soft ones. On microscopy, what do you find? Like microscopy, you will find three populations of cells. See, the dark ones are small lymphoid-like cells, the intermediate medium cells, and you can find the very large giant cells. Okay, so in HC, what you'll find the same of structure features as in seminoma, but placental alkaline phosphatase will be absent, and they do not metastatize these tumors. Hence, the prognosis will be excellent. So, summing up with these two tumors, which are seminomatous tumors, germ cell tumors. One is a classic one and the spermatocytic. So left, taking the classic one, they usually grossly will come with age. Usually it comes in the 30s, whereas spermatocytic, it occurs in people greater than 65 years of age. Next, coming to the position, usually unilaterally in classic type, whereas in spermatocytic, it will be a bilateral presentation. Grossly, how will appear in classic one, it will almost replace the entire testis. Whereas this spermatocytic one, it will be gelatinous and it occupies only a portion of a testis. Okay, now coming to the microscopic picture. If you see the classic one, you can classically see the large polyhedral cells with a centrally placed nucleus, and particularly the lymphocytic infiltration in the intervening fibrous stroma. Whereas the spermatocytic, you can see the typically three cell population here, like the small one, intermediate, and the large one. So we have finished the primary germ cell tumor with no tissue differentiation. And we will next go on to the primary cell tumor with embryonal differentiation. To start with that, first is the embryonal carcinoma. So this germ cell will usually a germ cell will undergo an embryonic differentiation and extra embryonic, I told. So this one embryonic, the first differentiation become you can get the possibilities of embryonal carcinoma or a teratoma. So first we lead with the embryonal carcinoma. Okay, so this embryonal carcinoma, it occurs in individuals aged 20 to 30 years, and these tumors are very aggressive in nature. Cytogenetically, there'll be presence of 12p isochromosome. Usually, the patient will not have any pain. There'll be painless enlargement of the testis. So, if we find testicular enlargement at this age group and it is painless, then we have to search for the embryonal carcinoma. Okay, so grossly, how will it be? I told you it is the smallest germ cell tumor, and usually it is about 2.5 centimeters, and on cut section it will be gray white with areas of hemorrhage. The surrounding this tumor, you can see the normal testicular parenchyma. What do you find on microscope? You can find all the cells like this. They will be on light microscopy pleomorphic cells without much differentiation, and they will be high rate of mitosis because it's very aggressive tumor. It keeps on multiplying. Therefore, a lot of mitotic figures will be encountered, will be seen in noticed, and it will not take a particular pattern, and the tumor cells will be found will invading the blood vessels. So this sort of picture you will get in the light microscopy in embryonal carcinoma. So having finished the germ cell tumor with embryonic differentiation, one is the embryonal carcinoma. We move on to the next one is a teratocarcinoma. Okay. These teratocarcinomas can be found at any age from infancy to adulthood. Okay, usually they can arise from more than one germ cell layer. Like they can a combination of from the ectoderm, mesoderm, endoderm. Many component structures arising from any of these components can occur. They are called as a teratomas. See, this picture actually gross it as reduced, but I'll show in the next slide. Grossly, it will be around 5 to 10 centimeters, and it will be heterogeneous because it has derivatives from all the three layers. It may be a solid or cystic in nature. It may have a cartilage areas and even hair structures and all that. Okay, how will you classify these teratomas? If it contains a mature elements, we call as a mature teratoma. Immature elements, it's a immature one. And those teratomas which it has along with if it has a malignant component with a malignant transformation, we call as a teratomas with a malignant transformation. Okay, so what do you see microscopy? As I have told you, if it is a mature teratoma, you will find derivatives from all the ectoderm, endoderm, and the mesoderm. That is a mature elements like the neural tissue, thyroid cartilage, bones, muscles, livers, and all. Usually, the mature teratomas are benign in nature. You can see in this light microscopy. See the rightmost left side, you can see the squamous epithelium with the keratin inside. So it's derivative of the ectoderm. And the left side, extreme side, you can see the cartilage over there. This picture also, above you can left side, you can see the mature cartilage. Along with that, you can see the hair follicles which are derived from ectoderm in the lowermost part, and the glands also. This is a mature derivatives, mature elements which from the ectoderm, mesoderm, and endoderm forms the mature teratoma. Okay, how will the immature teratoma appear? They will appear grossly as fleshy ones. Usually like this, it appears like a fleshy one, no? So grossly these teratomas will be fleshy in appearance. Whereas the mature one, however, they were areas of solid and cystic areas with hair follicles and all that. Whereas this immature one, it appears fleshy. And microscopically, you can find the primitive neural elements. These are all the rosettes like arrangement of the structures are all the primitive neural elements which are present, derivatives of neuroectoderm. Okay, next the subheading of the, we have finished the mature teratoma, immature teratoma. Then we will move on to the teratoma with the malignant transformation. Like they will contain malignant tissues like squamous cell carcinoma. These teratomas may contain malignant tissues like squamous cell carcinoma, sarcoma, or mucin secreting adenocarcinomas. So if it has all these things, we tell them as a teratoma with malignant transformation. Okay, now we have finished the germ cell layer derivative. From that, the embryonal aspect, embryonal carcinoma, teratoma, we have finished. Now we'll move on to the next segment, the germ cell tumors. It's an extra embryonic, derived from the extra embryonic tissues. So extra embryonic tissue, what are all the components may be there? It may be the placenta or the yolk sac. I have already told you. If they derive from the placental component, become a chorea, that is not the placental component, that is a line of development. Okay, so they will form the choriocarcinoma. So first when extra embryonic tissues, germ cell layer, will deal with the choriocarcinoma. Okay, these choriocarcinomas, like the embryonal carcinomas, very malignant and rapidly growing. Usually they will be found in the second or third decade. Clinical features, usually the person present with the metastasis producing the clinical features. Okay, so so much of metastasis will occur in this patients. It will be extensive areas of hemorrhage, so this causes a rapid spread of this tumor. Grossly this will have that picture with the hemorrhage. Okay, microscopically, because they are placental origin, you will find the cytotrophoblastic cells and the syncytotrophic cells. So what are these two cells? So they are the components of the placenta. Like cytotrophoblastic cells, they are single regular cells, regular polygonal cells with a centrally located nucleus. Whereas the syncytium means is a connection like. So they will be multinucleated cells, irregular multinucleated cells with a hyperchromatic nucleus. So we expect these two cells present in the carcinomatous component. So in this choriocarcinoma, we will find sheets of cells with both components, cytotrophoblastic components as well as the syncytiotrophoblastic multinucleated cells, and you will find areas of hemorrhage and all. So this will be typical HN light microscopy picture of a choriocarcinoma. Okay, IHC, if you see IHC, they will be positive for the beta HCG. Okay. Now we have finished germ cell tumor, which first one we have finished the extraembryonic one, the choriocarcinoma. Then we will move on to the yolk sac tumor. Okay. So yolk sac tumor, it is always called as the endodermal sinus tumor. You have to, yolk means young, you have to remember. So usually at the age group up to 3 years, it may be found. And the prognosis is very, very good in these patients. Increased serum alpha protein will be found. They actually origin from the primary germ cell, and they will show differentiation towards the yolk sac and allantoic membrane. Excuse me. Sorry. The origin of the primary germ cells forming towards showing differentiation towards the yolk sac and allantoic membrane will form the yolk sac tumor. The pathogenesis is thought to be due to hypermethylation of RUNX3. The molecular genetics, there will be loss of 1p and 6q, and there will be gain of 1p to 20p and 1q, 20p and 12p, 12 isochromosome. Okay, how will the yolk sac appear grossly? You have to remove the yolk in the egg. So usually this picture shows the gross and the light microscopic picture. So we'll see the gross. See the gross, it will be, you have to remove the yolk of the egg. I told you, know, they will appear yellow with the solid and the cystic areas. Usually they are 2 to 6 centimeters and well demarcated. Okay, they will show areas of hemorrhage and necrosis. So microscopically, typical of you will find in this yolk sac tumor, you have to search for the Schiller dual bodies and the hyaline globules. What are they? The Schiller dual bodies, you can see the central vascular space. So central vascular area is surrounded by the tumor, single layer of tumor cells. And around that you can see the empty space, and again you find the layer of tumor cells. So this gives rise to glomeruloid-like appearance. So this is called as the Schiller dual bodies. And you will also find the hyaline globules. Hyaline globules are nothing but the pink eosinophilic bodies, which are fine. So when you suspect a yolk sac tumor, you have to correlate with the age, the gross finding, and search for the hyaline globules and the Schiller dual bodies. Okay, now we have finished the primary germ cell tumor with a with a non-seminar metastatic. You finish the teratoma, embryonal carcinoma, choriocarcinoma, yolk sac tumor. Next one is a mixed sex cord tumors. So what is a sex cord tumors? Germ cell tumors. Non-germ cell tumors takes another track from the primary tumor. This picture shows the seminiferous tubules. Apart from the non-germinal germ cells, the tumors which are arising from the other structures are called as the non-germ cell tumors. So in that, we will first deal with the Sertoli cell tumor. What are these Sertoli? Okay, the tumors which arise from these cells are called as the Sertoli cell tumors. Okay, so They are usually benign in nature and secrete the estrogen and androgens. Hence, they are also called as the androblastoma. So, how will they present? They will present grossly as a well circumscribed nodule with yellow and cystic areas. Here you should note we have already read that Yolk Sac tumor also will present as a yellow tumor. In the sertoli cell tumors also present as yellow tumors with cystic areas. Okay, this is how it will present grossly. Okay, microscopy, what you expect? Certainly only cells will be there. See, the other germ cells, everything will be absent. The mature spermatids will not be present. The extreme right of the picture, two slides I have put, no? The other slide is a normal seminiferous tubule, whereas the left side, the Sertoli cell tumor, you can find only the Sertoli cells. So this is a Sertoli cell tumor. So this is also another picture of a light microscopic picture of a Sertoli cell tumor showing the seminiferous tubules with only the Sertoli cells. So we have finished the primary tumor, non-germ cell tumor, Sertoli cell tumor we have finished. Then we will move on to the Leydig cell tumor. So where are the Leydig cells? I have already told these Leydig cells are the cells which are large abundant cytoplasm which are present in the between the seminiferous tubule in the fibrous septa. So those tumors which arise from these Leydig cells are called as Leydig cell tumors. So usually at what age they are common? They are common between the 30 to 45 years of age. Usually they synthesize testosterone and androgens. Because they synthesize testosterone at this early age, they are responsible for they will cause precocious puberty. How will they appear? They will appear as a golden brown nodule and it will be well circumscribed. Okay, light microscopy, how will appear? I told you between the seminiferous tubule and the fibrous area, they are the large cells with central nucleus and abundant eosinophilic cytoplasm. So the left side, you would find only sheets of large cells with the abundant eosinophilic cytoplasm and centrally placed nucleus. Okay, this is the light microscopic picture. Then moving to another entity, this non-germ cell tumor, this granulosa cell tumor. They resemble the ovarian counterpart, same thing in the testes also. They secrete the estrogens. How will they appear? They will appear as solid and cystic areas, with yellow-brown areas also. So, when you suspect a granulosa cell tumor, you have to search for the Carl Exner bodies. Okay, usually they will on light microscopy, the pattern of arrangement of these cells will be micro or macro follicular pattern, and these Carl Exner bodies, they will be having they are nothing but the cells which surround the pink mass, which I'll show you in the next figure. So this is a light microscopic picture showing, see, the rosette-like arrangement of the cells there, but they're not rosettes. Central pink areas are surrounded by the granulosa cells. This type of arrangement is called as a Carl Exner bodies. So if you find this type of cells, you have to suspect a granular cell tumor. Okay, next is a mixed germ cell tumor, mixed sex cord and germ cell tumor. So they are called as a gonadoblastoma. So 10th tumor which we are discussing. Usually they will be found in the intersexuals. Okay. And undescended testes are more prone for this. They are the combination combined. In this tumors, you'll find the proliferation of germ cells as well as the sex cord stromal cells. So how it will be how will it appear? It will appear in variable size and hemorrhagic. This will be the heterogeneous appearance on gross, the mixed sex cord and germ cell tumors. Okay, so because light microscopy, what do you expect? It is a mixed one, a tumor, no? So you will expect, you should expect varieties of tumors here. You can see the seminoma on the left upper aspect, large polygonal cells with a clear cytoplasm. The teratomatous element here with the epidermis and the glandular pattern here. Then you can find the embryonal carcinoma on the lower aspect with the immature cells and poorly formed gland. So we have, you can see all the mixture of all these components, epithelial component, sex cord component, as well as the pure germ cell components. Okay. So now I have like a piece, I have put all those together. Now we come back to the classification chart. We have finished the classification: primary germ cell tumor, non-germ cell tumors, that is the Sertoli we have finished, Leydig cell, gonadoblastoma, and the adenocarcinomas, the mixed tumors. So all these things we have finished. Now we'll move on to the next one, which is a secondary tumor. What are secondary tumors? It is not native. It is a secondary deposit to the tissue from some other place. So what all can you expect is you can expect a lymphoma. Okay, lymphoma, you can see the see how on gross you will find the gray white areas. It is like a lymph node, it will appear. So what do you expect? Usually the non-Hodgkin's large cell lymphoma are more common in the testis. See the way above you have the uninvolved seminiferous tubules, whereas the lymphoma are involved in the lower aspect. Next is a plasmacytoma. So what is a plasmacyte? The cells which constitute them will be plasmacytoid. How will the plasmacytoid cells appear? They will appear with a, they are large oval cells with a peripherally pushed nucleus and eosinophilic cytoplasm. Usually it will be basophilic in the blood. Okay, in the testis it will be it will take this site of this type of staining in H&E. Next is the metastatic tumors. See, metastatic tumors arise to the testis from any organ like lungs, prostate, kidney, stomach, anywhere it can appear. In the skin, if there is melanoma, you will get the deposits here also. Okay. Now we have finished the primary tumor, secondary tumor, then we will move on to the paratesticular neoplasms. What are paratesticular tissues? Right, apart from the tissue, testis proper, the surrounding structures and all you have, no? From those structures which surrounds the testis, if the tumors arise, they are called as the paratesticular tumors. So what all constitute the fibrous structures, the adipose tissue, the blood vessels and all. So if benign tumors may be there, and even the malignant one, but they are not that common. So benign tumors, you can expect a lipoma or a hemangioma constitute of the benign blood vessels, or a fibroma. Malignant is concerned, the rhabdobiosarcoma is found, but it is very rare and usually arise from the distal spermatic cord. Okay, usually it appears like a scrotal mass or like a presence like a hydrocele. Okay, so for any tumor, now we have finished all the neoplasms. Now for any tumor, there should be some marker, no? If we test the blood sample, if we find some marker, it is positive, then we can suspect a tumor. So because of the recent advances, these tumor markers are helping us in early diagnosis and better management in the follow-up also. So this is just a rough guide. Rough sketch showing seminamatous tumor. Usually they were positive for the tumor marker HCG. And if the early embryonic stage, the embryonal carcinoma, the HCG, they may be HCG positive or they may show positive for the alpha fetoprotein. One or both, or neither may be absent. Next, if you next Yolk Sac tumor, it will be positive for the alpha fetoprotein, and if it is a choriocarcinoma, elevated level of HCG levels will be found. Okay, so we are coming to the end of this testicular tumors, and this is the overall testicular tumor classification, and I have assembled them. I have assembled them together to get this picture. It's very hard to simplify in this online class. But if you have any doubt regarding this, please let me know for the further betterment. And now I'm coming to the end of this testicular tumors, and I will switch on to the prostatic benign prostatic hyperplasia and the prostatic carcinoma now. It will take another 10 to 15 minutes to finish the class, prostatic class. Ma'am, Phoebe ma'am, what do I do? Shall I continue now, or ma'am? Ma'am?
Anirudh? Anirudh,
Yes, ma'am.
what do you feel? Ma'am will finish in 10 to 15 minutes. So go ahead.
Okay, ma'am. Whatever ma'am feels.
Illa, up to you. You are, I mean, if you are tired, she will take it in another class.
I don't. 1 second, ma'am. Okay, ma'am. You can go ahead.
Yes.
It doesn't tell. I have only few sites, pa, because it will be a
Yes.
Yes.
continuation. I'll finish
Yes,
it
ma'am.
off.
Yes, ma'am.
Yes,
Yes,
Take
ma'am.
your own time.
Thank
yes,
you. Thank you so
ma'am.
much, ma'am.
Anirudh, is this visible, pa? Is this visible?
Yes, ma'am.
Okay. The next topic will be about the benign prostatic hyperplasia and the prostatic carcinoma. Okay. The terminology benign prostatic hyperplasia, that is to indicate what it is. Hyperplasia means increase in the proliferation of number of the cells, right? And it is because of the prostatic gland, you call it a prostatic hyperplasia. And because of its nature, it is benign, you call it as a BPH or benign prostatic hyperplasia. Usually it is present in men greater than older than 50 years and results in the nodular enlargement, and there'll be proliferation of both the stromal cells and the epithelial cells, and usually they will present with a urinary obstruction. What is the etiology and pathogenesis? Actually, the main androgen in the prostate is dihydrotestosterone. As you can see that dihydrotestosterone, they are naturally, it has to be derived from the testosterone. So it is formed from testosterone through the enzyme type 2,5 alpha reductase. This enzyme is usually located in the stromal cells, and those enzymes convert to testosterone to DHT or dihydrotestosterone, which binds to the nuclear receptors and stimulates the growth factors. Now this picture, you will find this picture, you can find clearly. See, the testosterone is there. So the left side you have the stroma cell, the right side is the epithelial cells of the prostate gland. So what is stroma? The area which is outside the epithelium. Okay, the epithelial cell is a glandular epithelium. So now we can see in the stromal cell you have the 5 alpha reductase that converts the testosterone to dihydrotestosterone or the DHT, that will activate on the nuclear receptors and stimulate the growth factors like fibroblast growth factors. They will cause a proliferation of both the stromal cells and epithelial cells, and thereby result in the hyperplasia of the prostatic gland. Okay, so morphology. Now, usually this prostatic gland, benign BPH or benign prostatic hyperplasia, usually occurs in the inner aspect of the gland or the transition zone. See the figure, which is number 3, which surrounds the urethra, that undergoes hyperplasia. Okay, increase in the number of cells. So so the proliferation increase in the size also, so thereby it goes and obstructs the urethra. So the patient will find difficulty in freely passing the urine, and they will present with the urinary obstruction. So this central area of the transition zone of the prostate will be affected here. How will you clinically diagnose it? When you do a per-rectal examination, you will find a lump you will be able to palpate a lump. Okay. Then you have to confirm with the other modalities also. So when we receive a grossly a specimen, how will it appear? It will appear nodular, okay, and it will be pink and yellow, and it will be soft in nature. Because the prostatic tissue, you will, when you cut it, you will find the milky white fluid exuding out of the tissue when you receive that specimen. Okay, but that is because of the prostatic secretion inside. What do you expect on microscopy? Light microscopy, you will find the proliferation of both the glands and the stromal elements. No, so there will be glandular proliferation, and small to cystically dilated glands will be there. of note here is that these glands will be lined by two types layers of epithelial cells. Okay, the inner columnar one and the outer cuboidal one. So but the diagnosis cannot be usually made by needle biopsies because it will be very small for diagnosis. So this is the light microscopic examination, light microscopic view. See, these are all the small glands, and the number of glands has also been increased here. The stroma also, in between the glands you find the stroma, that also has been increased. These glands are lined by two layer of epithelium. Okay. Okay. Now, how will I told you these patients usually clinically they will present with the urinary obstruction. Okay. This is what is the benign prostatic hyperplasia or the BPH. Okay, this is a benign condition. Now, if we'll go on to the next prostatic pathology, today is a prostatic carcinoma. So, as far as the prostate gland is concerned, the adenocarcinomas are most common. It is made up of glands. So the adenocarcinomas are more common in the prostate gland, and usually men older than 50 years are prone for it. The androgens as usual play an important role in this. The androgens, role of androgens can be substantiated by the fact that when we give androgens for the therapeutic effect, for the treatment with the anti-androgens, we can know the role of the androgens in maintaining the growth of the prostatic gland. Okay, well, the common genetic alteration is hypermethylation of glutathione S transferase gene. This causes the downregulation of GSTPI expression, thereby leading to the prostatic carcinoma. Okay, grossly, how will it appear? I told you in BPH, usually it involves on the central or the transition zone of the prostate. Whereas here in the prostatic carcinoma, you can find this growth, it occupies the peripheral zone. And moreover, it was soft, here it is gritty and firm on section, and local extension to the other periprostatic tissues also may be noted. To the seminal vesicles or the bladder also can be found. And usually they do metastasis by the lymphatics to the operator node and the parietic nodes, and it also undergoes it metastasizes through hematogenous pathway also. You have to look for particularly in the axial skeleton. This bony metastasis usually in this prostate, it will be osteoblastic in nature. When you find that in a X-ray, you have to suspect or search for the prostatic tumor. Accidentally, if you happen to take an X-ray or you come across that osteoblastic metastasis lesion like in the X-ray or CT, you have to search for the any pathology in the prostatic gland. Okay, never miss that. How will it appear on microscopy? I told you it's nothing but gland and stroma. Prostatic is made up of gland and stroma, right? So these glands, they'll be glandular pattern, but when compared to that of the benign prostatic hyperplasia, these glands will be smaller ones. Okay, and there I told you in BPH, the glands are lined by two layer of epithelium, whereas here it will be only a single uniform layer of cuboidal cells. The outer basal layer of these glands will be absent. Okay, this picture you can see that there are enlargement, there's cells there. It's an actually the adenocarcinoma. You can feel the mucinous adenocarcinoma. You can find the mucin on here. You have to these glands does show only a single layer of epithelium. The outer basal layer is absent. Okay, and in this prostate we have to usually look for the perineural involvement. Usually the perineural invasion will be present. It may be present. You have to look for it. When you receive a prostatic tissue, you have to look for the perineural invasion because it is more common. Okay, majority of the prostatic carcinomas are positive for alpha methyl isomerase, and approximately 80% you can see it will be positive for PIN. What is PIN? it is prostatic intraepithelial neoplasia. So how will it appear? Architecturally, like that of cytologically, architecturally, cytology, everything like the pin and the prostatic intraepithelial neoplasia and carcinoma, they may be identical. But unlike carcinomas, in the pin, you will find the patchy layer of basal cells as well as the intact basement membrane. So you have to look carefully for those areas to rule out between the pin and the frank carcinomas. Okay, this helps in the staging and treatment purposes. Okay, so as far as prostate is concerned, the grading and staging is important for early diagnosis and better treatment. Here we use the Gleason system of grading, and staging we use TNM classification, tumor node metastasis. Okay, because they have good prognostic indicators. Additionally, the measurement of the PSA level assists in the diagnosis and management of the carcinoma. PSA is prostate specific antigen. Okay, it's a product of the prostatic epithelium. Normally itself you can find minimal quantities in the semen, but only few minute quantities it will be found, but it will be elevated in the case of advanced cancer. The only disadvantage is that it lacks the sensitivity and the specificity. Next, coming to the tumor node metastasis, the TNM classification. If it is not palpable usually and or palpable microscopically only, you classify as T1. T2, if it's confined within the prostate gland. T3, it comes out of the prostatic capsule, and T4, if there is fixation of the prostatic gland and or it involves adjacent structures. Then node, as far as concerned, regional nodes, if it involve, you stage it as N1. Metastasis, if there is no regional nodes, M1A, metastasis M1B if it involves the bone, and M1C if it involves other sites. So this it will be given in your Robbins. You can go through it easily. This Gleason's pattern need a little explanation too, because studying these pattern uniformly brings less confusion between the surgeons and the pathologists. When they come to a common platform understanding, they identify as a well-differentiated, moderately or poorly differentiated carcinomas. This helps them to early identify the patient and treat them so that they recover at the very early stage. So coming to the Gleason's pattern 5 patterns are there. One is the pattern 1, you have small uniform cells, right? Small uniform glands will be there. Next, pattern 2, you will find glands but more stroma. The stroma between the glands is increased. Next, third pattern, you will find the infiltrative margins. Next pattern, you will find the irregular masses of neoplastic glands. Like they will not be glomerular pattern will be there, poorly formed glands. And pattern 5, only occasional gland formation. You have to search for any gland formation. They'll be poorly glommed. You cannot find any gland as such. They'll be very poorly formed. Okay, so based on that pattern, you give a score for that and then you grade it. Okay, so if the pattern is 3 plus 3 is score 6 and you grade 1, what does it say? 3 plus 3, see majority only from 3 we grade it. Okay, 1 and 2 we leave it off. So what is 3? Majority of the glands which we see in the microscope, we put it the first number 3, and the minority of the glands, what you see, you put it as next number. So you add it and get a score. For example, you take the second one, 3 plus 4 is 7. What did they say? Majority were the 3 pattern and the minority were of the 4 pattern. So together they add up to pattern 7 score and they graded as grade 2. But if you see the next one, 4 plus 3, that also added up to 7, but it came under, because my majority were under 4 pattern, the 4th pattern, that is the glomerular pattern. Okay, so that the grading is varied. That helps in the prognosis. They decide the prognosis of that cancer. Okay, this is the pattern which helps us. This was formed by the WHO, so that there is no confusion between the pathologists and the surgeons, and help the patient to be identified at an early stage, group them, grade them, and give them treatment. Okay, so what talking about the treatment, what are all the modalities of the treatment? First, it's a surgery. Then you can do a radiotherapy, and of course the hormonal therapy. They blocks the androgen receptors, and gives additional mode of treatment for this prostatic carcinomas also. Okay, coming to that was the end of this session, and I have finished the prostatic benign prostatic hyperplasia and the carcinomas also. So we have covered 3 topics altogether today: the testicular tumors, the benign prostatic hyperplasia, and the prostatic carcinomas. And I hope I was a little bit clear in presenting the classification. Because it is an online, I'm not able to give a in-depth idea of each and every tumors. But if you go back and read this table, what I have put in the PowerPoint, or if you go back and read the Robbins, you can get a clear picture of all the tumors. I've just given an idea about these tumors. And regarding these 2-3 topics, I have some notes also, which I will share to Dr. Sweta. If you want, you can get it from her and share it. In case I wasn't clear in any aspect, you can, and you have doubt, you can call me and get it clarified. And thank you, ma'am, for
excellent. Madam has taught you what exactly you are expected to write in the exam point of view. Okay, thank you, Dr. Akila.
Thank you, ma'am. It was an elaborate topic, and I had to, because it is a online one, I have to split the classification into groups, and then like a maze, I have to assemble them like a jumble. And I've tried